Hi, everybody, and welcome to the April edition of the Research Roundtable with Dr. Karen Herbst. And today, her special guest is also a friend. Dr. Lindy McHutchison started Carolina Vein Center, which is now Center for Vein Restoration. She was in the forefront of diagnosing women with lipedema back when few people were even talking about it. She is an expert when it comes to vein disease. And in fact, one of the papers that they will be discussing today reveals that the number one comorbidity of women with lipedema is vein disease. What's going to be so invigorating about this conversation is these two are friends. So we get to be a fly on the wall, listen to the conversation. We're so glad for those of you who have logged on. Let us know that you're here in chat. If you have any questions for our guests, please do put them in the Q&A and they will get to them as the conversation flows. But sort of like when Harry met Sally, I'm going to start this conversation with Dr. Herbst. When did Karen meet Lindy? And then I'll disappear.
But I'm going to let Lindy take that one. Lindy, go ahead.
So I was a gynecologist. I mean, I'm technically still a gynecologist, but I was, so I have, a OBGYN background, and then I've been doing venous disease for over 17 years now. And around 2016, 17, I started to notice these legs, get more interested in legs, learned that they were lipedema. And then I decided that I wanted to go to a lipedema meeting because my worlds of OBGYN and veins were sort of colliding. And I found this lipedema meeting, and it was going to be in 2 weeks. And I said, oh my gosh, got my team together and joined, and then got connected with Karen because she heard we were vein people, and got just completely thrown into her research. And we literally became fast friends within a 2-week interval of the first email to meeting her, and we've been friends ever since. So it's like you're like my twin sister.
Yep, I feel the same. Yeah, and it was actually, I think you contacted the Lipedema Foundation, talked to Felicity Daftoir, and then she contacted me and she said, do you need ultrasounds for your research? And I said, yeah, who is it? And she told me who it was. And I'm like, okay, we'll have a phone call. We had a phone call. And then I was finishing up my IRB, and I made you do your IRB training. And I'm like, oh, 15 minutes. And it was like 3 hours or something.
3 hours later. Oh my goodness. But we had such a good time. And and it's just, it's been a wonderful journey ever since. And I can't believe that so many years have passed now. It's been what, 5, 6, 7, 8, 7, about 8 years since this
8 years
all started. And I've been just really lucky. Karen included me on her standard of care committee, and I've been a part of FDRS. I didn't get to go this last year because I do mission work in Honduras, doing vein work. I've been doing that for about 15 years, and it was the exact same week and weekend of FDRS, so that's why I wasn't there. But I just love Karen, and then I met Brenda through this whole journey as well, and we are just a yaya sisterhood.
Yes, we are. So we did a couple things. So I was hoping that you would start out by telling us, like, what is vein disease? Someone's like, oh, I have vein disease. And as part of that, what is chronic venous insufficiency?
Yeah. Well, the irony about chronic venous insufficiency is it's actually very, very, very common. Like lipedema, it's a very common, little known condition, and it actually affects about 1 in 5 adult Americans. And basically what it is the arteries pump the blood from the heart to the body, to the organs, and then the veins return that blood back to the heart. And the thing about the veins are supposed to be working against gravity or antigrade from the feet up to the heart, so they can be, pumped to the lungs, get oxygen, and pump out again. And the way the vein returns to the heart against gravity is it has these one-way flow valves, especially in the legs where they have to really pump uphill. And these one-way flow valves keep the blood moving toward the heart. So as you walk and step, the calf and feet muscles work as pistons pumping the blood up, and then the valves hold it. So it's like a 3 steps up, hold it, 3 steps up, hold it, getting this blood against gravity to the heart. And when you have venous disease, one of two things or both can happen. Either those valves are weak and floppy, and then the blood doesn't flow uphill, it actually flows downhill, or the vein wall, the tissue in the vein wall can be loose or have laxity in it, and it can be stretchier than usual. So even if those valves function, they don't touch each other because the vein dilates so much. So you get, this vein dilation, the valves don't touch or they don't function, and the blood flows downhill, and it pools and causes congestion in the lower leg, especially the lower leg. And then that congestion causes hypertension or high pressure in those veins, which are not supposed to be there. And it just starts a cascading effect from there.
So what's the difference then between, because we were talking about this paper, and I think Brenda's going to put it in the chat, but this is a paper that came out of Switzerland, and they were looking at all the different comorbidities that people had, and they said the number one comorbidity that people had was chronic venous disease. But is that only chronic venous insufficiency, or is that like a catch-all?
Yeah, so the semantics and the terminology have changed over time. And chronic venous disease is actually an older term. And now what they're starting to use is chronic venous insufficiency. And insufficiency is just the term of that flow that is not flowing sufficiently forward. So they're both basically the same thing, but
Okay.
we usually that has to do with when we can use an ultrasound to actually look at that flow, and we can determine if that flow is flowing downhill. That's called reflux. So when a fluid goes in the wrong direction, it's called reflux. So like acid reflux, that acid's supposed to flow downhill, but it splashes up in your stomach. That's acid reflux. Well, with venous disease, the blood's supposed to flow uphill, but if it doesn't and flows downhill, then that's venous reflux. So the ultrasound evaluation in the clinic can actually determine if someone has reflux or the abnormal flow. And once you have that, that's when you get the label of chronic venous disease or chronic venous insufficiency. And it's usually coupled with the symptoms as well. So there's symptoms, there's physical exam, and there's ultrasound findings of the abnormal flow. And that all collectively is chronic venous disease or chronic venous insufficiency.
So you mentioned symptoms of chronic venous insufficiency. Are the symptoms of chronic venous insufficiency similar to those of lipedema?
Ironically, they're identical to them. It causes tired, achy, heavy, tender, swollen, crampy, restless legs, worse at the end of the day, better in the morning, better when you elevate. And if you can think of it, as the blood flows downhill, those veins start to fill, so they get heavy. Then the heavy leg gets tired. Then the veins start to stretch like a water balloon, and the nerves in the vein wall start to get achy. And then you can get some burning with that. Then the legs can actually get crampy. We think that's because the muscles are trying to get that blood out of the leg to make it feel better. The same thing with restlessness. We think it has to do with this muscle twitching, just trying to get the blood out of the leg. So ironically, they're the same symptoms: tired, achy, heavy, tender, throbby, swollen, crampy, restless legs, worse with long standing, worse with long sitting, and worse at the end of the day. Better in the morning when the blood's all drained out. You've been up, legs have been up all night. Better when you elevate your legs, you drain all that blood out. So that's why a lot of lipedema patients end up seeking a solution to their legs without knowing they have lipedema, because their legs are tired, achy, and heavy. So they go to vein clinics, and that's usually where they get their diagnosis.
So I think it's great that more and more vein specialists are getting to know lipedema. What is your once they get a diagnosis from a vein specialist, what else does a vein specialist offer? And what are typical frustrations that patients have when they go to vein specialists and get a diagnosis?
That's a great question. Thank you for asking it. So vein doctors treat venous disease, and they recognize lipedema, and frequently they actually do tell patients, I think you have lipedema. In most instances that I'm aware of, we try to give the patient information to guide them on a journey to help learn what lipedema is, because usually they're completely caught off guard with the diagnosis. They feel very validated that they have an explanation for why their legs look and feel the way they do. Then they sort of become a little bit despondent sometimes that there's not more they can do about it. And the lipedema patient is actually just so hungry for information. Of course they would be. So usually in the vein clinics will provide some information. It might just be a little pamphlet. We give out a lot more information, trying to help guide these women down a path of self-learning and self-care to help to learn more about their condition. Another thing most vein clinics can do, which we can talk about if you want to, is to help start the process and initiate the process to maybe order them a home compression pneumatic leg pump, which is covered by most insurance companies. And that is something that vein clinics and vein doctors are very familiar with ordering, because of lymphedema is part of venous disease. So not only can we give them the diagnosis, help get them on a pathway, we can help maybe get them a pump. Our frustrations is once we give them the diagnosis, most vein doctors don't know that much about lipedema. They know it is, but they're not, like I know about skin cancer, but I'm not a dermatologist. So most of the patients tend to turn to their vein doctors to be their lipedema doctor. And I think that's probably the biggest frustration that most vein doctors have, is that we're not lipedema doctors, we're vein doctors who know about lipedema. So I think that's the frustration, but we are very happy to give the patients the information and empower them with the diagnosis so that they can start a new journey on improving their quality of life with what they have.
That's awesome. Yeah, we need more lipedema providers. And we need more lipedema education courses, working on it. So, so we know that vein disease is often associated with lymphedema. Would that be fair to say?
Yes, they're sort of, it appears that veins, lymphedema, and lipedema are sort of triplet conditions. I call them, cousins, because they share so much. And while lymphedema doesn't trigger venous disease can be a trigger for lymphedema. It can be one of the quote causes to trigger lymphedema, and that's called phlebolymphodema, because phlebo means vein. So lymphedema is in the world of venous disease. In fact, our society is called the Venous and Lymphatic Society, the American Venous and Lymphatic Society. And now lipedema is sort of finding its way into our society too, because they have so much in common.
So getting into pathophysiology of the triplets. So I've seen people who just have vein disease and lymphedema, but then there are people, as you mentioned, that have vein disease, lymphedema, and lipedema. Is there a different pathophysiology to cause the fat to grow in lipedema? Because we know fat also grows in lymphedema. It's just different because it affects the skin as well as the underlying tissue, and you tend to see free fluid, whereas in lipedema or lipedema, let's say, the skin's pretty good. It might be a little thin, but it doesn't have that thickening like lymphedema, but you get this huge thickening of the subcutaneous layer. what are your thoughts on how that grows differently in the two conditions?
I don't know. It's a $64,000 question, but we
It
do
is.
know that at the microvascular level, they have a lot of similarities. Venous disease and lipedema, basically, the microvascular pool is identical. It has at the layer of the glycocalyx and all the inflammatory mediators, the words like the VEGF, the vascular endothelial growth factor, those are all elevated in both venous disease and lipedema, which makes me think that lipedema and veins are probably identical twins, and the lymphedema is the fraternal twin, because the lymphedema has other issues going on with it, other inflammatory issues. And like you said, it does stimulate growth, but it has more of a fibrotic effect, which veins can too. But I think that venous disease and lipedema are more closely related, and lymphedema is a secondary to both of these things.
Okay, so we have this paper that came out of Switzerland saying that the #1 comorbidity with lipedema is venous disease, occurring in 86.2%. Why do you think that is, that lipedema and venous disease go so hand in hand?
Oh gosh, well, I certainly think about this all the time at 3 in the morning when I wake up. And I think that they just there's something about the endovasculature that is so similar. And whether one triggers another, I think genetically they have a lot in common. I think they have the vein walls can be very compliant and very stretchy with venous disease, and we know that the fascia can be very compliant, and there can with lipedema. So I don't know the exact missing link between the two, but we do know that they are very closely related. And this paper confirms what I've seen in my practice. I've treated hundreds and hundreds of lipedema patients, and so I don't want to do a spoiler alert, but Karen and I have a manuscript in preparation that is supports this same study, and it takes, if you can imagine, taking this pie wedge and then expanding it, so it's going to look a little bit deeper into venous disease. But as I've been saying for years, it just seems like every single patient I saw with lipedema seemed to have venous disease. And whether to treat or not was something I would leave to the patient, because once we treat the venous disease, they're still going to have tired, achy, heavy legs, because we're not treating the lipedema part. So I like to tell them, you got these tired, achy, heavy legs, and when we take the vein comportion away, you're still going to have the lipedema component to it. We're just going to take away the vein component. And I tell them, I go, I don't know what percentage it's going to take away. Some people we take away 75 to 80%. Some it's only 5 to 10%. So I tell them, let's just say maybe 20 to 30%. If making your legs feel 20 to 30% better is worth it to you, then I think treating your veins would be worth it. If your legs don't bother you that much and another 20% improvement's not going to change your quality of life at all, then I'm like, no, let's don't do it yet. So that's sort of where I have that conversation with them.
That makes perfect sense. And I just had a patient like that today who's had venous insufficiency, but she didn't have enough symptoms and decided to get conservative treatment. So you mentioned treatment of venous insufficiency, even varicose veins, is a pump. So having a pump at home that you can use. What other treatments are available for vein disease?
So the treatments are basically focused on decreasing that pressure in the veins, that venous hypertension that's not supposed to be there. And that is the main focus. And so the way we do that is we have to stop the downhill flow. And you have to imagine this downhill flow or this reflux is like a waterfall effect when you stand up. And so to stop the pressure at the bottom of the waterfall, we usually just close the vein. It's a non-essential system. The superficial venous system is just a reservoir. There's no arteries, no nerves in this system. It's essentially a reservoir for the leg. It only carries about 10% of the blood in the leg, but it's responsible for 90% of the problem in the leg that we find. So, but we can eliminate these superficial veins like the saphenous veins and some of the varicosities that are abnormal, and improve the flow in the leg and not have any real adverse effect on the leg overall, because the deep system is it's underneath the muscle. That's where the bad blood clots are, the deep vein thrombosis are. That's the critical system, and that carries 90% of the blood in the leg. So by eliminating these abnormal superficial veins that are in the skin, that we can do that safely, and by closing those, we can stop or cease or slow this downhill flow in the leg veins. By doing that, we decrease the heaviness, decrease the tiredness, decrease the achiness, and then we sort of back out of those symptoms.
So you mentioned that you treat superficial veins. What are the superficial veins that you treat?
So a superficial venous system is, simplistically, you can think of it as between the muscle and the skin. So any of the veins that are on top of the muscle or between the muscle and the actual skin layer, or in the superficial or the superficial cutaneous layer, those are the superficial veins. And they have two main veins in the leg. It's basically like a circle drive. It starts on the top of your foot. And if the vein goes all the way up the inside of the leg, I should have brought a diaphragm. If it flows up the inside of the thigh, that all the way to the groin, longest vein in your body, that's the great saphenous vein. And it's usually only an inch or 2 inches under the skin. It's not very deep. If it flows on the outside of that little venous loop on the top of your foot, it goes around the back of your ankle and then goes up the middle of your calf, and that ends in the deep system behind your knee. And that's called the small saphenous vein. So the great saphenous vein on the inner thigh and inner leg, all the way to the groin, and the small saphenous vein are the two primary veins. And then I like to think of it like a river. When the river gets full, the banks of the river get wide. That's like the saphenous veins. The veins get wider in diameter. When they can't hold anymore, they overflow into tributaries. River overflows, these veins overflow. So with time, they overflow, and then there's branches, and they become larger and larger, and then they keep overflowing. And when a vein becomes 3 millimeters or greater, that's when it becomes a varicose vein. So 3 millimeters is the magic number. 2.9 and below by most insurance companies is considered more of a cosmetic vein. But as your body starts to overflow and overflow, you just keep making more of these veins. And in my experience, it's really a hard thing to measure. We see more of these varicose veins with progressing stages of lipedema. We don't see as much with stage 1 of the big varicose veins overflowing. But stage 3, you put the ultrasound on the skin and they just seem to be everywhere. So I know you've seen that. We have seen that on your thermography study that I did with you, I don't know, 7 years ago. And yep. You did the thermography study and you would mark the hot spots, and I came behind you and looked at the ultrasound, and indeed those were big varicosities under the skin. Because one thing, and I should have brought this up earlier, I'm sorry I didn't, most people think you have to have big old bulging varicose veins to have a vein problem, and that is absolutely not true. 90-something% of people's venous disease is under the skin. It's called remote from view, because their varicose veins are under the skin and they cannot see them. Okay, we can see them with ultrasound, but you can't see them with the visible eye. Clinicians get really good at it because we can sort of see the trends and the discolorations, the superficial things. We can see some of the skin changes that we see with lymphedema and advanced venous disease that we don't usually see with lipedema. So that was something we've got to figure out. But most people's varicose veins and chronic venous disease, they can't see it by looking at their legs. They're like, my legs look fine. I'm like, well, do you feel like at the end of the day, I had a long day, I need to get off my legs? And I'm like, yeah. And I go, well, you probably have venous disease. So that's one of the things, is the challenges, because people don't know they have it because they look at their legs and they think they're fine.
So, so we've talked about pumps and we've talked about some surgical treatments. Do you think that complete decongestive therapy is a good way to treat venous disease, lipedema, lymphedema?
I think complete decongestive therapy is an excellent way to treat venous disease because we know what it does at the macrovascular level on the larger lymphatic vessels and the veins. We think it probably has a big impact on the microvasculature as well. The hardest part about it, I like to describe using these pumps, is pushing back the tide. So they will push back the tide, but the minute you take your hand away from the tide, it's going to roll back in. So these pumps basically take the toothpaste and push it up as you can out of the tube and push back the tide. But the patients have to put compression on to hold it back because gravity's going to win. It wins with our faces, it wins with our bladders, it wins with everything, right? It's going to win. So that the hardest part is just we're fighting gravity 18 hours a day while we're awake. So it definitely has a place in venous disease and lymphedema and lipedema, no question, especially with advancing venous disease. The vein treatments actually stop that downhill flow and decrease that pressure. And so once you have vein treatments, you're less dependent upon a pump. But if that's all, if you're not a candidate for vein treatments, the pump is a great option.
So here's a question that I always get asked. You've probably been asked it a lot. And we actually had a debate at the American Vein and Lymphatic Society last year about it. But if a patient with lipedema is going to have lipedema reduction surgery, should she have her veins treated before the surgery or after the surgery? And I don't think there's a right answer, but I would just love to hear your opinion.
There's not a right answer, but I love this conversation. I personally think that it depends on the patient, because the reason that you would get your veins treated beforehand would be to minimize any bleeding. Because when those liposuction surgeons are going in that same subcutaneous space, that superficial space where the veins are, if someone has some large varicose veins, remember it's a venous hypertension, and they puncture it with one of those trocars or those catheters that they're using, you're going to get a lot of bleeding, and you're going to get a lot of bleeding fast. It's under a more pressure than it should be, not like a arterial bleed, but certainly you wouldn't want to cut your liposuction surgery short just because your blood loss was getting a little too high, when it's something that could easily be managed and probably is going to need to be managed anyway. So for that reason, we don't have a study on it. I think it would be better to treat your veins first. We're starting to, the orthopedic surgeons are sending their knee replacements to us now because they don't want to deal with all the varicosities around the knee when they do their surgery. So we're starting to see that more. The other thing I would add is having supported a lot of lipedema patients to their journey to get liposuction. I don't do liposuction, but I've helped write letters and I've helped support their diagnosis. That is a very, very long process. It can take months to get on a schedule for a liposuction surgeon. And so my thought is, hey, let's just get as much done as we can while you're waiting. So another reason is that I'm all about using your time wisely. And if you have venous disease and it's bothering you, you're going to wait, and it might help your bleeding, let's go ahead and do it. So I'm, of course, of the side of just get them treated if you need it anyway.
Awesome. And I've been doing ultrasounds now for a while. I quantitate lipedema just by the thickness of the tissue and two published papers. But while I'm doing the ultrasound, what I'm seeing is these small vessels that run with the tissue, so it's horizontal, because they're lying down, and they're thick. They're very thick, and I call them battleships because of the game Battleship. And you see all these battleships lined up. They're just lined up all throughout the tissue, and you can see sometimes the veins are thickened. And so I'm wondering, are these, and I could be wrong, because I'm not a radiologist or a vein doctor, but when I see these small thickened vessels, I'm thinking they're getting thick from one of two reasons. Either one, they have higher pressure in them than they're supposed to, so there's some high venous pressure deep, or they're inflamed, and that's why the walls are thickening. Have you ever seen that, and what are your thoughts on that?
Yeah, I see that every day, and what you just said is exactly true. You're spot on, right. It is a pressure situation, and when something's under pressure, it does get thicker to try and keep the pressure in. Veins is also, it is known to be an inflammatory condition. The inflammatory mediators at the microvascular level are elevated. They get inflammatory skin changes with venous stasis. The venous ulcers are related to that inflammation as well. So chronic venous disease, chronic venous insufficiency is considered an inflammatory condition. So exactly what you said is true.
Awesome. So there we go. And I also can see the little vessels, and you see the halo around it. So they're leaking. And if it's high enough in the tissue, right under the skin, you see the kind of like a halo around it, and you can feel it as a nodule, but then you could see the superficial fascia dips down, like it's heavier, like there's fluid coming out, pushing that superficial fascia down. Would that be correct?
That's exactly what's happening. There's so much pressure in these veins that it is actually pushing fluid out of the veins and causing swelling. And that's why the vein legs are usually worse at the end of the day, better in the morning, because you go to bed at night and it sort of can reaccumulate. But it is pushing a lot of that fluid into that interstitial space, or that space between all the tissue. And that fluid's all inflammatory. It's we don't really know the sort of the final verdict on it, but the lipedema tissue, the microvascular literature all supports with venous disease, these inflammatory mediators that are in this tissue that are not supposed to be there.
So when we talk about vein disease, we usually talk about chronic venous insufficiency and varicose veins. We don't talk about microvascular disease. So what is anyone studying microvascular disease, and what can we do to treat that and that inflammation component of it?
Yeah, as far as I know, no one's treating it. I did a presentation on this back in October, and I found one paper on the microvasculature of chronic venous insufficiency, and it could have easily have been a paper with lipedema, because it mentioned the same, inflammatory 10 inflammatory mediators, proteases and macrophages and all of those inflammatory chemicals. I don't know that there's a particular treatment. There are some vasoactive supplements that are very helpful. One is diosmin, which you have lectured on, written on, and hesperidin. Those are the two main ones. You can take witch's broom and some of the others, horse chestnut. But the diosmin hesperidin formula, especially the MPFF, the micro purified flavonoid fraction, that actually seems to be the one agent, which actually is a supplement, over the counter, that works on the microvasculature in lipedema, in lymphedema, and in venous disease. So while there's not a treatment that you think of, there is a medical supplemental treatment that actually is very, very functional, very good. I don't know if I can mention types here, but there's one that is it's not a regulated by the FDA or anything. You don't need a prescription for this. You can buy it over the counter. You can buy it on Amazon. The dose is 1,000 milligrams twice a day. So 500 in the morning, 500 at night. There's actually a lymphatic portion formula that also has vitamin D and selenium in it. But this is something that I advocate every one of my lipedema, lymphedema patients and a great deal of my vein patients to actually take. And I'm happy to provide that information to Brenda on the one that I recommend.
Okay, great. I totally agree. I wish you mentioned earlier the connection between connective tissue disease and lipedema and vein disease. I really wish we understood that connection more, because I totally agree with you. There's something going on the microvascular level, and that's been unequivocally proven for lipedema and venous disease. And we know that, like, there's different ways of getting lymphedema, but once you get lymphedema, you're going to have something similar there as well. So I would love to see more microvascular disease talked about at the American Vein and Lymphatic Society. And because I think you got to start from where the problem is, and that may be one of the places where it starts. So we have a ton of questions, so I am going to go through a couple of these. Let's see. So you mentioned that you see less venous disease in stage 1, more in 2 and 3. So what if a woman with lipedema stage 1 has some venous disease? Would you treat her, or you want to wait till she progresses in stage?
Well, ironically, if I see a stage 1 lipedema patient, I do see venous disease in those. I see venous reflux and vein dilation. I would only treat if that patient's symptoms were affecting their daily activities, and if improving those symptoms by only 20 or 30% would be worth it to them. Now, maybe I'm going to improve them by more. I can't predict, but anecdotally, that's just what I tell patients. So it would basically be based on symptoms.
Okay, that makes perfect sense, because you don't want to, if they have no issues or problems, then compression and pumps, right? And just
and
complete decongestive therapy.
Yeah, to help slow the progression if those things helpful, and we think that is. Plus, insurance covers chronic venous disease. It is a medical condition, and medical insurance covers it, and almost every policy that I know of covers it. Now, each policy has different coverage guidelines, but to be eligible for treatment under medical policy, you have to have your activities of daily living affected. They don't have to be prevented by your legs. They just have to be affected. So at the end of the day, if your legs are so tired, aching, and heavy, you just want to get off them and just like, oh, I'll start dinner in a minute, fold those towels later. Just give me a break. I'll do those dishes and I'll take the trash out. Just give me a break. My legs are tired. I need to get off of them. If it affects your activities, then insurance does cover the treatments.
Awesome. So we have an interesting question from Leslie Gladney. She says, are you able to see these veins well in darker skin tones?
Absolutely. We can. Now, we don't see spider veins as well, because patients with a darker skin tone, so Black, Middle Eastern, Mediterranean, more pigmented skin, they have the same amount of spider veins as the lighter skinned patients. You just can't see them as well. In fact, if we see a patient who says, I'm getting married next week, treat my spider veins, I'm like, girl, go get a spray on tan, because I can't get them treated in time. But just get some pigment on your legs, and that's going to help cover them up. As far as everything else, under the skin, pigment doesn't matter. It's all on ultrasound. We see all these veins under the skin, small, medium, and large, and the pigment of the skin makes no differentiation or no difference whatsoever. So we can absolutely see everything we need to see on ultrasound.
So I'm going to combine a couple questions here between Ray Wood and Linda Ann Kahn. So Ray's asking, can you see venous insufficiency in legs where they don't have lipedema? For example, could you see venous disease in people who have Derkham's disease?
So can you see it with your eyes? So seeing venous disease usually has to do with either seeing visible varicose veins or seeing typical skin changes, which is it's usually on the lower leg, having some redness, some eczema. The inflammation can cause eczema, dry, flaky skin. It can cause some darker pigmentation to the lower leg, partly from inflammation. It turns the melanin system on to increase the pigmentation, and also it can cause pigmentation by all that pressure we're talked about. That pressure can actually sort of force the hemosiderin in the blood directly into the subcutaneous tissue, and it's like a tattooing effect from the pigments in your blood. And it can cause venous ulcers. So there are some visible signs of chronic venous disease that, yes, we can see in patients without lipedema or lymphedema. In fact, we don't see those advanced skin changes in lipedema very often. That's actually very uncommon. I think it has to do because the laxity in the skin, and then the fascia and the thinness, the skin sort of expands and doesn't build that pressure that we see in a non-lipedema patient. And so, of course, Derkham's disease could absolutely be able to see the signs and symptoms of lipedema. And any Derkham's patient,
Venous disease, right? Venous disease.
Venous disease. I am familiar with Derkham's disease because of my affiliation and friendship with Karen. But if someone's legs are tired, achy, heavy at the end of the day, you just like, oh my gosh, I need to get off my legs. And you have Derkham's disease, I would definitely get that looked at, because again, you've got a pain condition. And even with the fibromyalgias, I tell the patients, I go, what if I can only take away 10% of your legs discomfort? They'll say, I'll take it. Because when you talk about, one of my favorite quotes that I love, that my father told me, he was a doctor and he remembered, he says, of all the pleasures life can gain, 'tis not in treasure, but relief from pain. And that is so true. And so any patient with a pain disorder, if I can take away 10% of their pain and that makes them any better, I'm willing to do that.
So we have a couple more questions about males versus females. So we know that more women have lymphedema, more women have lipedema. I'm wondering about chronic venous insufficiency. What kind of is the percentage of males versus females in those diseases?
That's well described, and it's 3-to-1. We see 25% male and 75% female. And that is because the number one cause of venous disease is genetic. Okay, so there's probably something to do with lipedema there. The number 2 is pregnancy, because each pregnancy makes that great saphenous vein wider and it never goes back to its pre-pregnant state. So with each pregnancy, you get more chances of venous disease. And the third is female hormones. Those female hormones, especially that progesterone, starting at puberty, those monthly cycles, that progesterone causes smooth muscle dilation, and the legs start to can swell more because the muscles are starting to dilate every month. And so between the pregnancy, female hormones, and the genetics, women have venous disease 3 times more than men.
So if somebody were going to pump their legs, this is a question from Rachel Ariza. If they were going to pump their legs, would it be more beneficial to pump at night when your legs are feeling heavy and you've got more venous hypertension, and have the effects of lipedema, or in the morning?
Oh, well, that's also a great question. I mean, obviously pumping at night would help, because then the problem's already occurred and you're making the problem better. In the morning, technically, for venous disease, your leg veins should be empty, and they're the most empty, so there's the less pressure. So in the morning, pumping for venous disease is probably not as important. maybe on a preventive, pumping at midday if you could, but certainly if you're wearing compression throughout the day and your legs are tired, achy, and heavy, putting that pump on is going to make a difference. So I guess if I have to vote, I'll say end of the day.
Okay. So a question about vein ablation. So is this like whack-a-mole? Once you ablate one vein, doesn't that put more strain on the surrounding veins, which then you have to treat again over and over?
Yeah, so once you treat the one vein and you close off the vein, it does reroute the blood to healthier flow. Now, remember, the superficial venous system is nothing more than a reservoir. It holds about 10% of the blood in the leg, and you can eliminate those veins, and you have miles and miles of veins to go around. If you took all the arteries and veins in the body and you lined them up end to end, they would wrap around the earth twice. So we're talking about miles and miles, even of the microvasculature in the leg. So there's plenty of veins to go around to carry that blood. But remember, I just said, the number one cause for venous disease is not pregnancy. It's not your hormones, it's genetics. And what I tell people, genetically, your veins cells are weak. Your vein walls are weak. And so even though we're going to close these veins, your vein's going to reroute to a new vein that is also weak. So I tell them it's like going into a town that was paved with weak asphalt. Okay, the busiest streets are going to give out first. Then you're going to be detoured to the smaller streets that look good, but they're going to break down. So genetically, your veins are weak. So sometimes we just do a little bit of tune-up. But I like to tell people there are a lot of worse things you could be born with than venous disease, because it's at least something we can manage.
So one of the things that we talked about were the leaky vessels and how it kind of pushes down that superficial fascia, and it even kind of causes that superficial fascia to almost disappear, at least by ultrasound, probably because it's full of fluid, and maybe it's even being pushed outwards by fat. So what I tell people is that after they have their lipedema reduction surgery, that's going to remove some of the stress on the fascia, and help it kind of rejuvenate. Do you think having the veins treated would help that fascia grow back faster? That's from an anonymous attendee.
We don't see in straight venous disease in patients without lipedema, we can identify that fascia pretty easily. We don't see the same fascial changes in venous disease that we see in lipedema. And I've seen those changes that you've talked about. If we have a lipedema patient, then we do see it. And that fascia gets really thin and it breaks up a little bit. You don't see it as well because we need those fascia planes. So the fascia is like, it helps. It's like fences in the leg. It creates these planes, these trampoline layers. And we depend on being able to see that on ultrasound to know where we are in the leg, what plane we're in, what compartment we're in. And we tend to see them pretty well in normal venous disease. So it doesn't do the same thing, in my opinion, that lipedema does.
Mm-hmm. Do you think it would get better though after you, let's say you stop a big leak? Do you think the tissue has a chance to heal if there's, if they use usual complete decongestive therapy, whole body vibration, eat right, exercise?
I actually, and I sort of postulated this in a talk that I gave in October, because if you treat the venous disease, you presume that a couple of things are happening. Your venous hypertension and pressure and inflammation are going to go down, and all those microvascular mediators are going to decrease. So you took a pool and cut it in half. And that sort of makes sense, theoretically, that that's what we're doing. So that would absolutely affect the fascia and the inflammatory effects of the fascia, breaking it down with all that inflammation.
Mm-hmm. Yeah, I really do think that the body has an amazing ability to heal, and that fascia is a very complex array of fibers within the tissue, but that they can heal too. So, and I think that's I think wearing your compression after you have your surgery, using your pump, and, controlling what other venous disease you have left, because you're not going to treat the deep venous disease, right? And we're not going to treat the superficial vein issue that there is with, except, maybe some diazomin. So I really think that you have to continue conservative therapy to the best of your ability and listen to your body. And some
Yeah.
people might need compression for the rest of their life, some may not.
And what I tell patients is I wear compression every day. As long as, if I'm wearing long pants and a closed-toed shoe, I've got compression on. Compression is sort of leg help. The athletes are wearing it because of the inflammation. It helps improve the inflammation. And I tell patients all the time, I go, dermatologists don't wear long sleeves because they have cancer. They wear long sleeves to prevent cancer, to protect their skin. Every vein doctor I know wears compression. So compression is not only is it helpful with the pathology of venous disease, lipedema, and lymphedema, it also is just very protective and helpful to the leg and gravity in general. So
especially as we age, because aging is one of the risk factors for venous disease.
Yes, it's a progressive problem. It probably starts so that's a good question. When we look at 10-year-olds, we know, what came first, the chicken or the egg? Well, we know what came first. The genetics came first. Because when we look at 10-year-olds, we can get venous reflux in about 3% of 10-year-olds. So, I mean, genetically it's there. By the time they get, in their 20s, it's getting a little bit more. And by the time they get senior citizens at 65, about 35% of people have venous reflux. So we know that the venous reflux is there. It's just not causing a problem. So absolutely.
Okay, so this question is right up your alley. If someone uses a Mirena IUD, which secretes progesterone, and they think that their lipedema got worse, what do you think about that?
Well, it's been a long time since I looked at that. I am a gynecologist, but the Mirena IUD, and I will have to look this up. I don't think that the systemic effects of Mirena are that high. It's designed to have a local effect on the endometrium or the lining of the uterus. I don't know that the systemic or the absorbed effect and the effect on the whole body. I mean, it's going to have some. So I am going to have to look that up.
But do you think the body thinks it's pregnant? Do you think there could be other things going on hormonally or metabolically because the body thinks it's pregnant?
Well, with IUD, the body doesn't think it's pregnant, but with the birth control pills, it does sort of inhibit that ovulation with the birth control pills. So if I would suspect that if it was going to happen, it would be more with birth control pills than it would be with an IUD, because IUD is more of a local. It affects the reason it affects the period is because of the effects it has on the lining of the uterus, and not because of the systemic effects. And women can still ovulate. It's just that they're having these effects, very strong, directed effects on the lining of the uterus. But I'm happy to do a little bit of a deeper dive. It's a tough question because lipedema is so common, and birth control pills and hormones. If you look at it, there maybe 1 or 2 people are very sensitive to it, but we're certainly, I don't think, seeing masses of people that are getting worse, or I don't know, on birth control pills. That we don't know. We have a lot to learn.
Mm-hmm. So I think this is an important question. With chronic venous insufficiency, if you don't elevate your legs, do your toes typically turn a bluish color?
I love that question.
I know.
I get it very often. Thank you for asking it. Here's the irony. Veins pretty much stop at the ankle, so does lipedema, right?
Yeah.
And so you don't really see very many foot issues with venous disease. So no, your cold blue, discolored toes are not from venous disease. That's probably from a dysautonomia, related to like the to POTS or to other things like mast cell activation associated with lipedema. It is not related to venous disease. Those cold purple toes that get that is called acrocyanosis, and that is more related to the dysautonomia, POTS, mast cell activation, and not veins. There is one foot condition that is known to be associated with veins, and that's the tarsal tunnel syndrome. And that's like the carpal tunnel here, carpal tunnel, where you can get numbness and issues when you get pressure here. There's a tarsal tunnel, right, basically on the inner ankle, where the nerves and everything go into the foot. And sometimes the vein can cause pressure there, but it doesn't cause the blue toes.
Nice. So we talked about pumps a little bit throughout this talk. If somebody had just venous disease or, lipedema with venous disease, could they just use a basic pump? For example, a pump that maybe only went up to the knee or just up to the groin?
Of course, they could use whatever pump they had, and whatever pump they had is going to help. I think it is pretty well documented, and I'm pretty sure you documented it, that wherever you push that lipedema fluid and that lymph fluid and that interstitial fluid, whatever that gel is, that gag gel, it's going to make the tissue potentially worse. So if you have a pump that's only a knee-high pump, you could potentially be pushing the fluid to your knees and thighs and making that tissue worse. So then if you have one that pushes it all the way to the top of your thigh or mid-thigh, it's going to stop there, it's going to stop where it pushes it. And then that tissue at the top of that pump could potentially get worse. So what I like to tell patients is I really recommend that they pump up and over. They got to go up and over their abdomen, up and over their apron, up and over their big, large hip and buttocks tissue, and get it up and over so they can get it into their heart and their circulatory system so their kidneys can process it. So I prefer the pants, the pneumatic compression pants, to get it all the way up and get their pelvis and their abdomen congested as well.
And what about for venous insufficiency, just real quick? Can they just use any pump? Does it matter as much?
The venous insufficiency, they can just use a thigh high if they don't have lipedema, because all you're trying to do is get that fluid into the thigh, into the groin, so that fluid will get into the deep system in the groin and up, because that is a different, that you're trying to get blood out of the veins, not out of the tissue. And so when you're using it for venous disease, you are moving tissue fluid as well, but you're trying to get the blood in the veins, squeezing it up into the deep system, which happens in the groin, to get up.
And what about just a knee-high pump? Is that sufficient? Because, they're selling a lot of pumps on the internet, and I just, I kind of worry about the knee-high ones.
I think a knee-high pump would be useful in a very specific situation. Some patients have a hard time with thigh-high pumps. They have bad backs, or they can't bend over, or they maybe they have a venous ulcer where they just need a localized, specific one area of treatment, and just getting the pressure out of the lower leg is paramount. So I think they do have a place, they do have a role. It's very, very rare for me to prescribe one, because usually if you've got a problem in the lower leg, you've got a problem in the thigh, and we just need to just get that problem out of the leg completely.
Nice. And here I have inserted myself here because this conversation is riveting, and yet we are at the 1-minute warning here, which means time to almost wrap up. I just want to acknowledge a few things. First of all, Dr. Herbst and Dr. McHutchison, you should have a regular TV show. with the way this conversation has flowed, I'm seeing in chat such appreciation for all the material covered. We almost got to nearly 20 questions. For those of you who logged onto the live, thank you for giving us your time, because weren't the questions amazing as well? Just
Yes, very
simply
nice.
a wonderful conversation. You attendees help make the research roundtable what it is, which is fantastic. And of course, Lympha Press is so honored to provide this kind of content to you every month. We'll be featuring many more experts as the year goes on. And in a little bit of an announcement, because Lympha Press did sponsor this, not all pumps are created equal. And when you want the abdominal pantsuit, and when you want certain garments, not just the pumps aren't created equal, the garments are different too. We would love to help you out. If you're not using a Lympha Press to manage your condition, please do reach out to us at lymphapress.com. We would be so delighted to help you. Closing remarks. First, Dr. McHutchison, and then Dr. Herbst. Take it away, Dr. McHutchison.
Well, thank you for having me. It's a subject that I'm passionate about, and the funny thing is that when Karen and I do get together socially, this is what we talk about, which is probably why it seems so fluid. We just both talk constantly about lipedema and veins, and I just want you to everyone out there to know that the information that we have. It's all out there on the internet for y'all. This is the most transparent. All the researchers are transparent. We're trying to get as much information collected and out there to the lipedema patients to help you as much as possible. So just keep staying on top of the online forums, because you're going to be on top of all this information that we have.
And Dr. Herbst, to close out another amazing research roundtable.
I will say that, of course, I enjoyed this hour, but I totally agree. I think when we get our paper completed on taking a deep dive into venous insufficiency and lipedema, that we're going to need to have you back on to talk about that and what it means and how it can take the field forward. Because I think the more information we know about veins, lymphatics, fat, fascia, everything in the lipedema tissue, the closer we're going to get to making lives of people with these diseases better. So thank you, Lindy. It's been a joy.
So thank you, everybody, for a great evening. We hope to see you again next month. For Lympha Press, I'm Brenda Viola. Have a great night. See ya.
Bye-bye.